So the question of when and how to use risk stratifications in MPNs is one that, thank goodness, continues to evolve. And as we learn more about the diseases, as we learn more and can understand the impacts of our treatments, we need to continually update these risk stratification systems because you need to know what the question is that you want to answer. And then you need to know what is the most appropriate risk stratification system to use for that question. So one of the most common questions is, does this patient need to be referred for hematopoietic transplant? And I think that's where we've seen a lot of modernization come. And that's because our transplants are getting a little safer, but also we're knowing more about what the impact is of the molecular markers on the overall prognosis. So what I did in my talk for the SOHO group is go over the traditional models. For example, the IPSS, which was one of the, I would say, of the first of the more modern models for using MPN, and is most important when you're asking the question of, is this person appropriate for treatment with a JAK inhibitor? And that's because the COMFORT studies used IPSS as an eligibility criteria for putting patients on treatment. Then we have the dynamic IPSS, which are an improvement because they can be used at any time during the patient's course of therapy. And those are often used for consideration of hematopoietic stem cell transplantation for patients in the higher risk categories. And these can, of course, be modulated now by taking the DIPSS and looking at that, but also looking at the MIPSS 70 plus version 2. And this MIPSS 70 plus version 2 incorporates the traditional clinical factors, of course, with both karyotype and high molecular mutations. And those high molecular mutations, which include ASXL1, SRSF2, EZH2, and the IDH1 and 2, as well as factors like circulating blasts, severe anemia, karyotype, can help categorize people from very low to very high risk and predict outcomes in a relatively dynamic and contemporary way. Those groups are now being looked at as whether or not transplant is appropriate. And there is data as well on which of those what is the overall post-transplant survival using a pre-transplant MIPSS. It's important also not to forget that we have a separate risk stratification system for patients who have previous MPN, but who transformed to myelofibrosis from, for example, polycythemia vera or essential thrombocythemia. And that risk stratification is called the MySEC, and is also validated in that specific patient population. So in SOHO, I tried to summarize some of these. I tried to look at when you use which stratification to answer which question. But I guess our take homes would be, make sure you know the question you're asking. Is it about prognosis? Is it about treatment? Is it about transplant? And then use the transplant system that best fits that question. And I think with that, we should be able to really address our patients' goals with the appropriate risk stratification system. And I think you can also reassure patients that as our treatments improve, which we are continually working on, those risk stratification systems will need to be tweaked and evolve as well, because they're always based on retrospective data, which the outcomes improve as our treatments improve.